All right. Good morning, everyone. My name is Melissa, and I'm with Quality of Care NL. I want to welcome you to today's session of Healthy Discussions, which is our first session in 2025. Before we get started, I'll just have a few housekeeping notes. The chat box and the Q&A feature are both open, so feel free to use them. And you can also turn on subtitles, which are auto-generated by clicking the CC button on the bottom left corner of your screen. And lastly, this session is being recorded and will be posted on Quality of Care NL's YouTube channel in the coming days. I'd like to acknowledge that we're joining you from the ancestral territory of the Beothuk, and the lands on which Memorial University's campuses are situated are in the traditional territories of diverse Indigenous groups. We acknowledge with respect the histories and cultures of the Beothuk, the Mi'kmaq, Innu, and Inuit of this province. We invite everyone to offer land or territorial acknowledgements in the chat and to take a moment to reflect not only on why we offer these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. For those who aren't familiar with Quality of Care NL, we are a research and evaluation program based at Memorial University, aimed at improving social and health outcomes in our province. Healthy Discussions is a webinar series where we have quality conversations about health, healthcare, and social systems in Newfoundland and Labrador. Our goal is to engage with you on these topics with the aim of continuing public conversations during the ongoing process of health transformation in our province. Public discussion also contributes to the growth of a learning health and social system in Newfoundland and Labrador. On the screen right now, you can see a definition of a learning health and social system as defined by Health Accord and NL in its task force report. This definition might seem complicated the first time you read it, but what it really boils down to is a health and social system that continuously improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, resulting in better care and health for all. Part of that definition states that individuals and families are active participants in all elements. So by engaging in sessions like this one, by being an active participant in your own healthcare and wellness, by talking about and acting on issues that impact us as a society, you are contributing to a learning health and social system in our province. So today our discussion is going to focus on the topic of genetics, and that includes genetic testing and genetic counseling. We're delighted to have joining us today Dr. Lesley Turner, who is a clinical geneticist, Dr. Holly Etchegary, who's a professor of clinical epidemiology, Emily Bonnell, who's a genetic counselor, and Leona O, who's the regional manager of the medicine program at NL Health Services. And joining them for today's discussion is Quality of Care NL's director, Robert Wilson. So Robert has some questions to get our conversation started, but I will remind you that we will be taking questions from the audience, and you can type those in the chat or the Q&A feature. Since today's discussion is being recorded, you may wish to ask your question anonymously, which you can do by using the Q&A instead of the chat. So I'm going to throw it over to Robert now to get us started with our first question.
Perfect. Thanks, Melissa, and thanks to our guests for coming on and joining us. I'm going to get things started, and I got a question for you, Lesley. Can you kind of, just to get the conversation going, can you tell us a bit about the Provincial Medical Genetics Program? Because I understand why individuals in Newfoundland and Labrador might want to or get referred to seek out genetic testing.
Sure, and I guess just to start off, thank you very much for having us attend this session. We're delighted to share some information about our work, which we are very passionate about. So the Provincial Medical Genetics Program, it is a provincial program, so we service all of Newfoundland and Labrador. There's two geneticists, so myself and Dr. Chard. We have 9 incredible genetic counselors and administrative staff of about 4. We also have a metabolic nurse and a metabolic dietitian and our manager. So we're not a big group, but it is a great group. In the Provincial Medical Genetics Program, we see patients and families from every stage of life. So we see people prior to birth, couples who are referred planning a pregnancy who may have a genetic condition in the family and are interested in knowing their risks. We see couples during a pregnancy where there may have been a concern detected on screening or the ultrasounds. We see children and babies that may have a genetic condition and present with various different health concerns. We see adults. We see a lot of patients referred and families with concern regarding hereditary cancer conditions and hereditary cardiac concerns and neurology concerns. And also then we have our metabolic clinic. So Dr. Chard is involved in that and follows children and adults with metabolic conditions that may need specialized treatment with diet and various other treatments. So, and then finally, we see people, if there's been a sudden death in the family that's unexplained, sometimes we have family members referred and we obtain the autopsy and try to see if there's any testing that can be done that could be helpful for the family. So really, all stages of life, we're involved in individuals and families.
Perfect, thank you. Holly, I'm going to pass it over to you and just talk about like the uniqueness of Newfoundland and Labrador and what makes our province such a great resource for genetic research and studying.
Yeah, perfect. Thanks. So I echo my thanks for being here and say hi to Emily. We've never met before, so nice to meet you, Emily. Always nice to see all the clinical folks when you're a researcher in this space. So I think many of us will know Newfoundland and Labrador has long been thought of as a genetic gold mine, I think is how it's been referred in the literature or in social and popular media. So we have a founder population, and I'm sure most of us have heard that. Most of us on the line, even though I can't see you all, thanks for coming today, which really is a concept from population genetics, just referring to lesser, reduced genetic variation when you have a small group of settlers who settle a new place or who establish a new population. And I guess I use the word small group of settlers comparatively. So we know here in Newfoundland and Labrador, I think the number is about 90%, I want to say, of the population was settled from or descendant from 20 to 30,000. So that's the small number, 20 to 30,000 settlers from England and Ireland. And I think a lot of us here, you know, born in Newfoundland and Labrador, will trace our roots back, right, to English or Irish sort of roots. So when you have that relatively small population, it just means there's less variation. And so it makes it easier for researchers who are looking for genes or mutations or variants, as we call them, pathogenic variants or patterns, to find them because there's less mess. Right? We have a better signal to noise ratio as it's described. So it's just less messy, easier to see things. And in this province, and indeed, I'm sure in other founder populations, that will often result in seeing certain patterns in geographical areas or localized regions of the province. So I'm sure many of us have heard about Newfoundland and Labrador. We have a higher incidence of familial colorectal cancer, for example. Many of us have heard about the inherited cardiac sort of condition, ARVC. We know, you know, Dr. Jane Green has done tons of work here over the years, you know, about certain vision conditions, for example, and often you'll see them in certain areas of the province. So we have a founder population, which is just makes it easier to see variation. But there's a couple of other reasons, Robert. I think that Newfoundland and Labrador is a great place for genetics research. Part of that is we have large families. Maybe not nowadays. I think today people are not having 8 and 9 children, but years ago they certainly did, right? So we have large families that are generally close knit, which again, just makes it easier, I think, to find at-risk relatives, for example, right? And have those conversations. And finally, I would say we have an altruistic population. I think families here in Newfoundland and Labrador have long been very generous and very gracious about working with researchers, particularly when it's a condition in their family. They have a stake, right? A lot of people here, I'm sure some of you on the line, even though I can't see you all, will know that I do a lot of patient-oriented research, right? So I work with patients and families. I partner with them. They're teammates of mine. I actually think a lot of researchers here in this province, long before our national funder, created the strategy for patient-oriented research, I think we were doing it here for a long time. I think families really are very good and gracious about working with researchers. So you see why it's a good place, right, to do this kind of research.
Yeah, exactly. I mean, the days are few and far between now with families having such large amounts of children. I mean, my mother, for instance, was a child of 14. She has 13 other siblings, right? Which is incredible.
Yeah.
But those were some of the hard stats that like were coming from the health accord, that we are an older population because like, a lot of people post the collapse of the cod industry have moved out, and then people are having fewer children.
Exactly. Yeah, exactly.
I'll just bring it back to you. You talked about a few unique conditions that are, unique to Newfoundland and Labrador. So I'm going to bring it back to you, Lesley. How does someone within the province get genetic testing? And this is a bit of like a three-part question. Like, would you have to go through your primary care physician or nurse practitioner? And usually, how long would it take for someone once referred to get that testing or screening done?
Yeah, so we get many, many referrals from family doctors or nurse practitioners or other specialists, pediatricians, neurologists. So really from any source, any healthcare provider. And we do also have people who don't have a primary healthcare provider and can make a self-referral if there's a concern about a genetic condition in the family. We hope more and more that people will have a primary health provider, because that's critical in terms of, I think, the healthcare for our patients and families. And then we have quite a detailed triage process for all our different areas. And so we look at the referral and to decide the urgency. So certain referrals are very urgent and have to be seen right away. So for couples in the midst of a pregnancy, they can't wait. Newborns are triaged if very urgently. So if there's a condition that we think could be treatable, so there's treatment implications. So our triage categories would be sort of urgent, priority, semi-urgent, and then routine. And we hope that we are seeing our urgent and priority referrals in a very timely fashion. But that unfortunately means that our semi-urgent and routine wait lists are unacceptably long. So for some of those referrals, people are actually waiting 4 to 5 years to be seen. So we've been working at strategies to try to reduce these, but it's just really related to the volume and the resources that we have in terms of some of those wait times.
Right. And so, like, bringing back to your primary care provider, what kind of role do they play in the navigation of? I know that you can get referrals from your primary care physician, but do they play much of a role once this whole process begins?
Yeah, so I guess first of all, recognizing who needs a referral to genetics. So the primary healthcare providers are excellent at that, and in terms of if there's a significant family history of cancer or cardiac concerns. So then they would place the referral. We often then send out family history forms for people to fill out and then return to our department because we take a very detailed family history that can help with our assessments. When we see the patient, and often there can be sort of family members that come and do the assessment to determine if genetic testing may be helpful. There may be some screening recommendations then that are very important for the family. So we would send those recommendations back to the family doctors, who would then organize them for their patients. So the primary healthcare providers are really integral. We get many referrals and phone calls from family doctors or nurse practitioners about the service.
Perfect, thanks. And Emily and Leona, we'll get you in the conversation soon, but Melissa has showed her face, so that's usually the signal that there's questions coming in from the audience. So I'll pass it over to you, Melissa.
Thanks, Robert. Just a couple of quick, I think the answers can be fairly quick questions. Can anybody avail of medical genetic testing in a general sense, or do you have to be looking for certain disease, disorder, or symptoms of something present? Or can somebody, I guess, just if they want to know more about their genetic profile, avail of testing?
Yeah, so really through the Provincial Medical Genetics Program, any genetic testing is done because of a clinical indication. So we don't do broad genetic screening or testing. It would be based on an individual's history themselves, their sign and symptoms, or their family history, and the fact that there is a known genetic condition in the family. So we don't do any sort of population screening for genetic conditions at the moment. People can avail of that sort of privately, and some people do, but I would just urge a little bit of caution just for people to be informed about that testing and where they're getting it. Because there are companies that really don't do very good testing. So just to make that informed decision.
For sure. Thank you. And that kind of leads into a second quick question from the audience. Given that we do struggle with the wait list a little bit here, do you often see patients getting testing done outside of the province or elsewhere in Canada, or is it kind of something that each province takes care of itself?
And I guess, Emily, you can chime in. I mean, we do see some people availing of private genetic testing if there's a family history of cancer, say, and there are various companies that do provide quite good testing for hereditary cancer conditions. I would say we don't see a lot of people, we don't have a lot of referrals from people who've gone through the private system and have paid for testing. But that may increase, and of course we may not know about it. So there may be people who are doing this testing and it comes back negative, or they just never get referred to genetics. So we don't have a really good idea about those numbers.
And I'll just quickly add as well that genetic testing is something that's provincially regulated. So it's not like you could go to Ontario and, well, there is one private paid clinic in Ontario, but for the most part, you can't go to their public Ontario genetic centers and get genetic testing through there. It is something that is regulated by different provinces.
Okay, perfect. That makes sense. I'll give it back to you, Robert.
Can I throw something in real quickly before we
Absolutely.
move on? Sorry. I would just say too that in the literature, there's now quite a literature over the last 5 or 10 years about kind of trying to address new models, if you will, of genetic counseling, new ways of people coming through clinical genetic services. Because, by the way, wait lists are not just a problem in Newfoundland and Labrador. I'll be very clear about that. It's a problem across the country. In fact, it's a problem globally. Because the demand for genetic testing continues to increase, partly because of just greater awareness about it. These new private companies now, you swab your cheek, you send it off, you get back a report. The only data I have, by the way, for the province in terms of how many are doing that, it's just a small bit of data, but I'll share it. 5 years ago, or 2019 now, we did a survey of the public in Newfoundland and Labrador. And we had over 900 people took part, which was fabulous. And 13% of them had direct to consumer testing, is often what is referred to, direct to consumer. So 13% of that 900, roughly, okay, I don't have the numbers in front of me, but roughly, had in fact done that. And those, as Lesley said, she's quite right, the companies are very different, but there's a lot of them now. There's quite a lot of them now, and most of that testing is done without any form of counseling. So you swab your cheek, you get back your result. Then, of course, the question now becomes, do people have to go to their family doctor or some other provider to interpret those results? So it's a whole literature in and of itself. But I did just want to say that there is a movement towards different models now of trying to provide kind of services to people who have an interest in genetic testing. It's new, it's expanding. We don't yet know, I think, how effective it all is, but there's quite a movement now to do that, to look at alternate models of care.
Thanks, Holly.
Thanks, Holly. And it's kind of a good segue now because my next question's for Emily. And just so can you perhaps speak to the audience on the role of a genetic counselor and perhaps provide some examples of what a counselor would do for a patient coming in?
Sure. I always love a chance to talk about what we do. So I think in order to kind of talk a little bit about our role in a patient's healthcare, I need to first just kind of review who genetic counselors are for everybody, because not a lot of people know it is a newer profession. So genetic counselors are allied healthcare professionals with master's level training. And the master's that we do is really focused on the coursework on counseling techniques, as well as genetic topics such as inheritance patterns, genetic testing methods, as well as common genetic conditions. And this is all complemented by clinical rotations in various specialty areas. So we get exposures to everything, as well as often a research topic or master's thesis in genetics. And when we graduate, we do have to get certification, either Canadian or American, by writing an exam. And because genetics is a rapidly growing field, we also have to maintain that certification by going to a certain number of talks and conferences every year to make sure we stay up to date. So that's who we are. And that training gives us a good skill set to meet with individuals and their families. And as Lesley mentioned, we take a detailed family history, and from that family history, we can identify inheritance patterns, maybe potential genetic conditions a person's at risk for, and things that sometimes an individual might not be referred for, but we might want to get some more information, like if someone was referred for hearing loss. But then we note that there's a family history of lots of people with cancer at an early age. We might want to get a little bit more information on that for them. So based on a person's health information, family history information, we use all that to kind of determine, one, if genetic testing should even be offered to their case, because it's not always appropriate or relevant. And two, if there is genetic testing offered, what's the best and most cost effective, because we are, a provincial service, test to offer to that patient. And then we go over some of the benefits and limitations of genetic testing, because like any healthcare test, genetic testing isn't a perfect test. And we review, what the potential results could be, the implications for that person's health, their family members. And we talk a lot about things like insurance implications. We get a lot of questions on that as well. And all this information in this conversation we have with individuals really helps them make an informed decision in terms of if genetic testing is the right choice for them, if it is being offered. And if we do offer genetic testing, when the results come back, we also meet with individuals to go over the results, the implications for them and their family members. If a genetic condition is found, we review the health features. We help provide written communication that people can give to their family members to say, hey, this is the genetic condition. This is what you're at risk for. We also refer to specialists to help manage certain health features and provide support, because it is difficult when somebody does get a genetic diagnosis. And so I guess that's what we do. And I should mention as well that we don't do this alone. We do this obviously with the support of each other, all the genetic counselors here, and our two brilliant and excellent geneticists, Lesley and Marisa. And really they help us, and we review all cases with them. And sometimes we also work with other healthcare specialists to try and make sure we have best patient care, like talking with maternal fetal medicine or cardiology. That helps us, with the clinical presentation and helps us guide screening sometimes as well.
Yeah, I would imagine obviously like the interim period between going to get tested and waiting for results can be quite stressful for a patient, really, right? So I would imagine, within that counseling, it's not only the physical health, it's the mental health of a patient as well. So perhaps could you, I'm going off script here now, Emily, but it's making me very interested in the topic, but how does that play into the factor of your counseling?
Absolutely. I mean, whenever we meet with someone, we know that a lot of these conditions are really challenging and difficult. Some of them can be progressive or get worse over time. So we understand the genetic condition a lot better than some healthcare providers might. Like if, just going to your nurse might not understand a really rare condition. So just having that understanding can be helpful in terms of providing support to people. And I think the entire time that we're meeting and chatting with someone, we're always checking in with them, seeing how they're doing. And I know myself, like we always offer, you know, if you're having any difficulty, like please reach out to us. And for some people who might need more longer term counseling, which is absolutely something that we identify, will often help make referrals to more long-term counseling supports as well. Because like I said, it takes time to adapt to some of these conditions. Having this knowledge, it's not easy stuff. So we're always, you know, assessing for how a patient is and how we can best support them.
Great. And I guess this is a good segue for a question I got for you, Holly. I mean, your research focuses on the impact of genetic testing decisions and understanding why people make that decision to be tested or not. So what kind of impacts do people consider when making that decision?
Yeah, loads and loads and loads of them, I would say. I also want to acknowledge, by the way, before I answer that, but I will, and I do see some questions in the chat, so we'll come back to them for sure. But that was a good segue from Emily's. And actually, I'm happy for Emily and Lesley to weigh in here now shortly to tell me if you hear these sorts of things in clinic. Because here's the sort of things that I hear in research, okay? So coming from a research perspective, and many people I've interviewed over the years across a range of conditions. So I'll say a few things broadly speaking. I think that these decisions to undergo testing or not are complex. As Emily was just saying, these are tough, not easy decisions. So no one factor, I think, is ever going to influence them. It's always a myriad of factors, right? Partially what makes them so complex. I've also learned from participants over the years that decision making is often not a one-shot deal. It happens over time. It's a process. Emily, as you just said, people take time to adjust to this, and decisions may change, and they're influenced by a variety of factors. So I'll say those couple of things broadly. I think the features of the condition itself, again, as a broad factor, for what is someone being tested, that immediately impacts decisions. So are we talking about a pediatric condition, one that will manifest in childhood, or an adult onset condition? That alone can impact someone's decision. Will I be tested? Will I wait? Will I do it later or not? Is there urgency or not? Is there treatment available? People say to me, you know, I didn't bother to be tested. Why would I? I can't do anything. Simple as that. Others say, I absolutely had to be tested because if I know I'm at an increased risk for condition A, B, C, usually an adult onset one, I can do something about it. So whether there's treatment available. And penetrance, which in what we're getting at here is what proportion of people who test positive for a particular condition will actually go on to get the condition. So the classic examples we use, or I see in the literature, are Huntington disease, which is a neurological condition, quite an awful condition. It was where I first entered this space back in 2002. When I started researching genetics, it was with families affected by Huntington's. They were brilliant. They taught me so much, unbelievable. But in Huntington's, it's 100% penetrant, which means if you have a genetic test for that condition and it's positive, you will go on to develop that condition. You definitely will. Versus many of the inherited cancers. If you test positive for that particular genetic test, that particular variant, you will have a much higher risk of developing cancer, but you might not. You may not develop cancer. So think about that, for example. That right away influences people's decisions. And we see that globally in the literature. If you look at globally the uptake rates of genetic testing for the inherited cancers, such as breast, ovarian, colon, versus the uptake for Huntington disease testing, last time I looked at those rates, there were something like 15-ish% for Huntington's disease, maybe 10 to 20%, 50-60% for cancers. So right away, you see different decisions. So broadly speaking, the condition itself, I think, influences whether or not people choose to undergo testing. Other things people think about, I like to classify it, you know, lecturer as I am, in terms of sort of individual factors, family factors, and more societal or health system factors. So at the individual level, beyond some of this stuff that I've already said, I have heard quite a bit in my research, emotions really influence a person's decision, usually worry or fear. And that can play as a role in terms of facilitating. Yes, I'm going to have a test. I would be, I can't live with that uncertainty. I need to know what I'm going to face. So people choose to be tested to reduce uncertainty. But worry can also, I think, function in the other way. So some people, they're in my research anyway, they're in the minority, but they're definitely there, who choose not to be tested because, as they put it, it'd be too much of a burden. It'd be hanging over my head. I can't worry about it. I'd be thinking about it all the time. I just don't want to deal with that. So emotions can play a role either to facilitate or, I think, deter. And either decision is fine, by the way. It's whatever makes sense in a person's life, right? The other thing in terms of thinking about reducing uncertainty in a more positive direction, so people choosing to be tested, is because they want to do whatever they can for themselves or their child. So they want to be not just psychologically ready, emotionally prepared, but also behaviorally. What can I do? If I know I'm going to have a child who has a particular condition, maybe that child needs certain structures in the home, certain clinical supports, certain education supports. You want to get ready, you want to be prepared. If we're talking about the inherited cancers, for example, you will engage in earlier screening at a younger age and more frequent than general population. For example, some of the families affected by Lynch syndrome, which has a very high risk of colon cancer, some of those, depending on their family history, begin screening at age 25 with colonoscopies. And general population, the recommendation is 50, right? So it's a big difference. So for some people, it's reduce that uncertainty and allow me to do something, if it can be done. The other reason people are tested, I think, sometimes that they've spoken to me about is not only information for themselves, but for others. Genetics is by definition a family affair, right? And people have often said to me, well, Holly, I don't really need this testing. I'm in my 70s, I'm in my 60s, etc. It's not going to make any difference to me, but my daughter needs to have it. My son has children now. He needs to have it. So very much for other people. And again, I'm not saying that's a bad thing. That makes perfect sense to me. I'm pretty sure I do the same, right? It makes sense, right? So for other people. Some of it at the individual level is what I would best describe as a personality difference, because I can't think of a better way to put it. So some people have said to me, I'm just the sort of person, I just don't want to know. If I have to deal with something later in my life, I will. Just don't want to know. That's just how I am. Other people say, I need to know everything about my health. That's just who I am. I just want to know. So I think of it as kind of a personality type factor, even though I don't really know how to put that. So some of the individual level factors. Some of the family level factors, I think, the literature suggests that if you have families that are very open, have an open communication style versus a closed communication style, more talking about health conditions, often the uptake of testing will be higher in those sorts of families. I think sometimes you feel pressure to be tested because of your family. I remember years ago with that Huntington disease study I was doing, I remember one of the families talking about cousins in the family, very angry that the cousins were not tested. None of the cousins had chosen to be tested. And this particular person was very upset about that and was trying to convince them to be tested. I've had other people say to me, well, I didn't really want to be tested, but, my daughter wanted me to, so I did it. So I think there's family sort of influences. And then finally, I think there's broader influences, societal sort of influence. So Emily has talked about, insurance in counseling, talking about insurance. People do still have a fear of genetic discrimination, whether that's in insurance context or employment context or just stigma more broadly associated with conditions. Healthcare providers, their encouragement, their knowledge about a condition, they're talking with patients, that also influences people's decisions. Finally, then, what we just talked about earlier, we were talking about the increased demand for genetic services and new models kind of being developed to help meet that demand. There's some recent literature now coming out about some of these different models that involve something like a navigator, for example, often a nurse, but not always, someone who's trained by a genetic counselor, often, to be the go-to person for a patient or a family as they're going through genetic testing and services. Models that are using those navigators are showing much higher uptake rates of genetic testing. Mainstreaming models, which are genetics, non-genetics professionals, such as oncologists, for example, are beginning to order genetic testing, and they're seeing fairly high rates. So all of these different factors, Robert, sorry, I've gone on forever here. Forgive me, everyone. But they're complex decisions. They're not easy decisions. And I think that all of these different factors can and do play a role in some way. So I don't know, but Lesley and Emily, I'm really curious if you hear some of that in your practice. You must hear some of it, I'm sure. I hope, or I'm totally off base in all my research.
No, absolutely. I think you have covered a lot there, Holly, but and I don't know, I guess, Melissa, if you had any questions, but I mean, certainly I think in terms of genetic testing, it is an extremely individual decision. And our hope is that people can make the decision with the information that they need. So our job is really to help them make an informed decision about the testing, and ultimately to lead to better health outcomes for them and their family. I would say that, you know, many times in the pediatric population, parents are interested in testing because if they have a child with special needs, or say a congenital heart defect, or learning difficulties or seizures, they really would like to come up with an explanation to help them navigate through the child's life. And sometimes finding an answer, it doesn't mean that it's going to change anything, but actually just having an explanation for parents can be extremely helpful. So I think in terms of the pediatric patient population, families usually are interested in genetic testing if it's offered, whereas the adults can be more complex in terms of the people knowing, like, do they want this information? Are they an information seeker or not? But it is a very individual decision, and you know, trying to review that with the patients does take some time, and we want to respect their decision. So yeah.
And I got a great question that would that hopefully we'll have time at the end, that it was in with this sort of subject realm, but Melissa has shown face again, so I think the chat room is blowing up. So Melissa, do you have some questions?
Oh my gosh, I have too many questions to choose from. So thank you to the audience for being so engaged. And I apologize, I'm sure we won't get to them all during today's session, but I'll try to combine as many as I can. I know we still have some more questions on our list, especially for Leona. So just one question I'll start with here is a bit of a scenario case. Let's say that a lot of people on this call might be familiar with. One of our attendees asks, my mother recently passed away. She was diagnosed with a recurrence of breast cancer, and she mentioned to me that she was contacted by her cousin about testing positive for the BRCA gene, or BRCA is the acronym. Is this something my daughters and I should consider being tested for? So definitely a scenario that I'm sure many people in this province are familiar with.
Yeah, so absolutely. So that's a great question. And definitely for this woman, it's always said in terms of her losing her mom, but having this information could be very helpful for her and her children. So she should ask for a referral to the Medical Genetics Program. And again, she would get a family history form, and we would also send out what's called a release of information form to try to get the records if her cousin is willing to share that information, because it would need to be with the cousin's consent, about that genetic test result. And then what we would call cascade screening or testing in the family would be possible if the cousin did have a pathogenic variant, so an important what's called a pathogenic variant or a mutation in one of the breast cancer genes. So for sure, she could seek a referral to genetics.
Thank you, Lesley. And that kind of, there's, you know, several other questions kind of along this vein, but, and particularly here in Newfoundland and Labrador, people have shared scenarios in the chat where they, you know, heard of so-and-so or this particular gene in this family, and suddenly my mother's maiden name came up and it was this family from this region, and I think that's my family. And people have been asking, you know, is there a place that they can go And this will probably lead us into a bit of a privacy and security realm of the conversation, where they can find out what are some of these things that are common in Newfoundland and Labrador, different family names that would be connected to genetic disorders. You know, they've asked if there's like a public database, or is there anywhere they can go to find more information about, say, the particular region of the province that they're from, or different family names, like you said, like last names, we'll say. Again, I suspect this will lead us into a bit of a question about consent and all of that nature, but I'll just throw that out to anybody who feels they want to chime in.
Yes, I mean, that's a tricky question, and I guess Holly and Emily may have something to add too, but there's really no sort of database that's a public database that you could look up your last name and say, oh, this last name is associated with this particular genetic condition or variant. And that is based on sort of privacy. The best way is when people know about something in the family, if they have that open conversation to ask whether genetic testing has been done, and if they are able to get that information, to put that in a referral. There are some sort of papers published about certain genetic conditions and places in the province where it may be more common, but I think it's really would be more beneficial to kind of have a more in-depth understanding of your family, and really base the referrals on your family history and those questions versus if you're from a certain part of the province.
For sure.
Yeah, I agree. I was going to say the same. To my knowledge, there's no place you can go, so to speak. We know from some media coverage, I think, and from some papers published. You know, I'm thinking of the ARVC, the inherited cardiac condition, for example. You know, the team here did great work there, and that's been covered in the Telegram, for example, right, in traditional media. So, you know, you get a glimpse of certain conditions and where they are, et cetera, based on those sorts of stories. But I did certainly no sort of database. Yeah, I would agree. It really is about knowing your own background really well and having those conversations.
For sure. Robert, I'm going to let you continue on with our final questions there, and then we'll go back for more audience questions.
Perfect. Thanks, Melissa. Leon, I'm gonna direct my attention to you now. You keep the motor running in this program. So when reviewing referrals, does the program have any sort of process for determining the eligibility and urgency of one getting testing? And then perhaps I got a follow-up question. What are some of your ways your team is adapting to be able to best serve the people of Newfoundland and Labrador?
Thanks, Robert. I have to start off by saying it's a real pleasure to be here today, and I am incredibly proud to say I manage this group of health professionals. I've been with this team for almost 6 years, and I am amazed every day by the complexities of genetics and the expertise that this team brings, and their compassion for their patients, their advocacy. It really is something to be proud of. And we work really hard in our department. We are very cognizant of our challenges with our wait times. And as Dr. Turner said earlier, we really want to make sure that the most urgent of our clients can get service when they need it. And we have a fairly rigorous triage system. So each of our specialty areas have their guidelines established. We have regular meetings to discuss and review our referrals. And Dr. Turner mentioned a few minutes ago that, you know, we get as much information as we can at that time to make the best decisions for our clients by sending out our family history questionnaires and getting additional information from families, you know, more than what we would, you know, potentially receive in a referral. And we also ask for records when we know that there is something in the family history, so that we have an opportunity to acquire that information as well. And we use everything, you know, at our disposal to make the best decisions for our clients to ensure that they are seen at the earliest possible time. And we've also become, in the last few years, we've made some changes in how we work, and we've been able to introduce, we see patients in person, but we've also introduced Zoom for healthcare, so we can do virtual appointments with people anywhere in the province through video with them in their home. We also have telephone appointments available, so we try to accommodate patients and their needs, making sure that, you know, whatever method we use is appropriate for the care that the client needs. And we've also looked at how we provide services. So we have established group sessions, so we can see more people quickly or more timely. And I'll I guess add a little more information to that. The group part of our sessions, in some cases they're live, some cases we have a recorded presentation, but that's to provide the background information that we would provide to each person who is coming to us with a similar concern. And then those are followed up by individual appointments with patients. But it does allow us to see a higher volume of people in a shorter period of time. So we've introduced that in a couple of different areas. We do it for some of our cancer referrals, and we do it for some of our cardiac referrals. And we continue. It is an amazing team for always looking for more opportunities in how we can do more. And I'm sure there'll be more to come as we focus on this.
And if anyone was trying to find information about your program, Leona, is there anywhere you would sort of direct them to go?
Someday soon, I will say, we are working on an updated website for the public for NLH services, NLHS. And we've just recently compiled the information that will appear there. I'm not sure what the timeline for that is. So coming soon, I will say. Yeah. Perfect.
Melissa, that's the end of my questions. I'll pass it back over to you to see if there's any other questions coming from the audience.
Sure. Yeah, we have lots. And one that just came in that will continue on with what Leona was talking about, actually. Someone asked if there was a way to find out where their referral is in the triage system. Like, I guess we're looking at, you know, expectations for what they can plan for in terms of when they might be seeing someone at the Provincial Medical Genetics Program. Is there a number they can call or a way they can find out kind of where they're sitting in that system, in that wait list?
Yeah, absolutely. You can call our main line, and I'm going to hesitate now to make sure that I have the right number. It's 777. I'm going to look at Emily now. Is it
4363?
363.
I think it actually spells Jean on the phone pad. Andre told me.
777 Jean. People have been putting in the chat. GENE.
Yeah.
Perfect. Thank you.
Okay, great. That is good information.
And I was just going to say, sometimes when your call goes through, it still may be difficult for us to provide an exact timeline, which is always frustrating for people, and we do apologize about that. But it is just related to the triage process and the how referrals come in. So we would like to be able to provide exact dates, but it can be challenging.
Of course, yeah, for sure. I wanted to touch base, there definitely were a couple of questions, and I know we mentioned it a few times about the implications for life insurance. So somebody else asked, someone who I think might be a healthcare provider, how can healthcare providers who are not, you know, in the genetics field help reinforce some accurate information about the Genetic Non-Discrimination Act and make sure that there's continuity of care and people can continue to access testing and things of that nature? Is there anything healthcare providers should know or can do to make sure that they're alleviating some of those concerns for their patients when it comes to, well, will I be able to be insured and other things that they have those worries about when it comes to discrimination based on a healthcare issue?
I can start us off here, and then maybe Lesley and Holly can jump in. And so I think that's a great question, because oftentimes I'll hear from people, healthcare providers that said, like, you know, insurance is not a worry anymore, which since the implementation of the Genetic Non-Discrimination Act in 2017, which was upheld in 2020, it is true that insurers can't access your genetic test results to make a decision on whether you can be insured for something. However, I always say to people, they can take your clinical diagnosis. So if you have a clinical diagnosis of a heart condition already from cardiology, that can be used to either deny or charge higher rates of coverage. They can look at your family history. So if you have a family history with lots of people with heart disease, people who've passed away suddenly at young ages, that can be used to help make a decision in terms of coverage as well. So I always tell people they have roundabout ways of getting the same information if you have that clinical diagnosis that is outside of the genetic test result. Where it kind of puts some protection in is somebody who's at an increased risk for a known family genetic disease causing change, who wants to see if they need to have some increased screening. They're not allowed to ask about that genetic test result. But I also say if you're found to have that genetic change and need that increased screening, if you're followed by a specialist because of that, that can impact your insurance. So it is really complicated, and it is kind of a larger discussion. And so lots of people maybe already have coverage when they come to us because they're in adulthood, but it is something that other people like who are testing their kids take into consideration as well. But if somebody does have a clinical diagnosis, it's kind of, I always say, you already have that clinical diagnosis. That's information that insurers can access.
Anybody else want to chime in there? If not, we can move on to another question.
Yeah, no, I was going to say exactly the same thing, Emily, that if there's something clinically there, it's a part of it. The other thing that I'll say just quickly, people will sometimes say, to me, as you just said, Emily, when they're advising their children on when to have a genetic test, I've had many parents who have said to me, and I mean a genetic test for the inherited cancers and for Huntington's, these two projects I have done. And people have talked about, they tell their children, they're 17, 18, 19-year-olds, to wait until you have your genetic testing to, get your career, get your insurance, get additional life insurance, get your travel, do whatever you need to do, and then have your test. I've heard that many, many times, whether that's practical or not. And I don't know how many people follow through on that, but I certainly hear that quite a bit, to delay testing. I don't know how common that is in clinic, or if it's common or not.
I was just going to jump in and say it is commonly heard in clinic too. And one thing I will say, especially for those like cancer and cardiac risk where screening does start young, I do say like, I've told them to wait. And if it's one of these conditions where somebody can have a sudden cardiac arrest at a young age, like long QT syndrome, I always say, I understand that, but clinically we would recommend screening. And once somebody's having clinical screening, if it's picked up, then that kind of negates that. So it is a bit of a conversation, depending on the condition as well. You say, I understand, you want to get these things in place, but we would still recommend clinical screening because sometimes the result of not having clinical screening is a sudden death or an early cancer. So.
Yeah, definitely. And just to lastly, our focus is the health of the person. So we would never want somebody to delay a test that actually could make a huge difference. So it is a complex decision. And certain of the sort of cancer, hereditary cancer conditions, screening wouldn't start until a later age. So in that case, it may be okay to delay the testing. And we wouldn't recommend testing for those conditions for people under 18. So for some conditions, it is okay to delay the testing, but if there's any screening implications right now for that person, we wouldn't want them to delay that and jeopardize their own health.
For sure. One question we have in here relates to ensuring the security and privacy of a patient's genetic information and data. They ask, is it included in a patient's medical record that presumably other healthcare providers in different areas would have access to, or is it kept separately?
So that's a great question, and I guess it is sort of a changing area in terms of technology. At the moment, the majority of our genetic tests and panels and whole exome sequencing are sent out of the province. And those reports come back to the genetics clinic. So they're not readily available on the what our Meditech, except in our letters that we do in terms of results. But we do have an initiative here, the CTG, Center for Translational Genomics. So we will hopefully be doing more testing in-house. And then that data will be available in our lab in terms of the genetic information, but really would only be able to be accessed by the circle of care, people who are involved in that patient's care, and not widely by anybody else. So our circle of care sort of privacy rules would mean that that information is private and shouldn't be accessed.
Great, that is good to know. And that kind of brings to mind another question about where is the testing actually done? Do we do that in province? Is it sent out of province? Or it sounds like CTG is a method we hope to be able to do more testing in directly here at home.
Yes, so we do certain genetic tests for some of the family mutations and the founder mutations that we know about. But right now, really the majority of our testing does go out of province. But hopefully very soon we're going to be repatriating some of that testing to be doing in-house, which would be great. So that is a lengthy process in terms of getting that up and going, and there's been people working very hard on that. So we're hoping that will happen soon, that we'll be doing some more testing in-house.
That's great, thank you. Another question, one of our attendees indicated that they had genetic testing done as part of a research program, something that happened here at the university and within the Faculty of Medicine. So Holly, I wonder, is that something, I guess it would depend on a particular type of research project, but is that something that is common where people would consent and be part of a research project and get some testing done?
Yeah, it's completely dependent on the project. Yeah, absolutely. And actually, getting back to the data privacy sort of question, I was thinking in a research project, there are as many rules around that as well, and people will get to see a consent form and see exactly what those rules are. It's been my experience, people often don't read those consent forms very carefully, but all that information is there, you know, where data is stored, how long it's stored, who will have access, etc. The genetic testing in research most definitely was completely and utterly dependent on the project. I know that has happened, and I know in many cases, like a lot of my research, for example, doesn't involve any genetic testing. People have already had a test result. So totally dependent on the research project. And it's a tricky situation sometimes, right? Because the results of a research test may have implications for clinical care. So then you have that very close relationship, right, between what's research, what's clinical care, and who can access that data is governed totally by the consent form for the research project, right? Sort of thing. So it's really a matter of very carefully understanding the project you're in, and what exactly is included in it, if you will, whether that's testing or not. And then it's possible you may then have to go down a clinical route if you have a test that was done in a research program. My understanding is that you would want that, I mean, Lesley, Emily, would you want that confirmed clinically, I think? Is that correct to say?
Yes, so if there's a research group that's doing research on a specific area and somebody does get a result that is suspicious that there's a pathogenic change or a mutation, we would want that to be confirmed in a clinical accredited lab. And we would hope that it's true, but it may not be. So if it is a research result, it really should be confirmed.
Okay, Robert, I know we've reached our 1 hour time here. I was hoping to squeeze in one more question. We still have most of our attendees on, so thank you guys for sticking with us throughout this whole conversation. One quick question, and it may or may not be quick, I guess, but we've spent a lot of our time today focused on different genetic conditions and screening that often would be adult onset or relating to cancer or other diseases. And someone in the chat just made a comment. They said, as one of the midwives in the province, I just wanted to express our appreciation for your program. So I just wondered if we could just spend the last minute or two just commenting a little bit on that area of genetic testing in terms of prenatal screening and for people who are pregnant.
Yes, well, thank you very much for that comment, and we're delighted in terms of the midwives now in the province, and have had some great relationships with them. Sort of the prenatal area is really very emotional, of course, in terms of seeing couples who are either at risk of having a child with a serious genetic condition, or are in the midst of a pregnancy and an ultrasound has detected concerns like a heart defect or kidney concerns or differences in the way the brain is developing. So those patients are referred and seen urgently. We have a great team at the Janeway with the radiology department, maternal fetal medicine, and we review the findings and really sit down and go through them in a lot of detail with the couple. We've got several great genetic counselors, David and Courtney, who do the prenatal area. And sometimes testing is possible, so people can choose to have genetic testing during a pregnancy through procedures with an amniocentesis or chorionic villus sampling. And again, those decisions are very individual. Some people are interested in that testing, some people aren't. Some people want to have the information just to prepare themselves if the child does have a genetic condition, or make a different decision about the pregnancy depending on what's happening. So they're often extremely emotional sessions, and our role is to help the couple or the individual make the decision that's best for them at that time in their life, because that can also change for couples depending on their age and what's happening in their life. So very emotional, difficult sessions that we hope we provide as much support as we can for that patient population.
Sure, thank you. Definitely, we've learned today the work that you do is, I imagine, highly emotional and definitely has an impact on a lot of people, and yourselves included, I assume. Robert, I'll pass it over to you to clue up the last.
Yeah, for sure. I mean, this healthy discussions perhaps could go on for the rest of the day. It's very interesting, but I'm very mindful of the time, and I'm very mindful that you guys have taken the time on your busy schedule. So I'm just going to personally thank you guys, Holly, Lesley, Emily, and Leona, for taking the time to come on our program and talk about a very, very interesting subject. Without further ado, we'll say goodbye. I'm going to pass it over to Melissa to clue things up. So thank you to all our guests as well.
Thank you, guys. And I'll just express my thanks to you all as well. Just for our attendees, you're going to see a very short post-event survey on your screen after we end the webinar, and we'd appreciate you providing any feedback or ideas for future healthy discussions topics. And thank you to everybody who joined us online, participated in our discussion. You really made the session fly by. And a reminder that there's a recording of this session that's going to be up on our YouTube channel in the coming days, and you can check out recordings of all the previous sessions there as well. So lastly, thank you everybody again for joining us, and I hope everybody has a great rest of their day.
Thanks, everyone.
Thank you. Bye-bye.